So now we're going to turn the page, and we're going to talk about surgery of the knee. And we're not going to scare you. And we're going to show you some really marvelous advances. And one of the first things we're going to show you is this is what an actual knee replacement is. And the first thing I tell my patients is many of them don't realize that this is like a crown. We're like a dentist. And it used to be that patients, and it used to be many years ago that we'd actually remove the whole knee. But now what has made knee surgery so successful is that we keep all the bony stock and we keep the outside ligaments. So the surgeon makes these real fancy cuts, and there's a lot of different instruments that we have to be able to make these cuts. And then on top of this goes this crown. And this actually replaces the arthritis that you have. So that is very important that we get it lined up just right. The tibia cut is an easier one. It's nice and flat. And then this is the product that is called the rotating platform. And that rotates and gives a little bit more natural motion. Now, I do have to tell you some more special things about this. First, many patients come in and they say, do you have the female knee? And that's because of advertising and marketing. And they get on the internet, which we encourage, but they get all of these different marketing claims. And I do have to tell you as a little bit of a disclaimer, all of the really big total knee companies, they all have excellent products. And they work well, and they really help a lot of patients out. All of them have sizes for males and females, and all of them are very similar in their metals. There's a little difference occasionally from the metals. This happens to be the rotating platform. This implant has been available for almost 20 years. And patients say, how long will it last? 93% are still in place at 20 years. And that's a great track record. And we think we now have such good total knees that in many patients, it used to be we'd say, well, maybe in 10 or 15 years we're going to have to do another. We think that we'll probably have one total knee for a patient's life. And that's the goal. You want to have surgery that we don't have a complication, that we get this put in correctly, that you get good motion, that you get good function, that you keep your muscles working, and that this knee then can do a very good job for you. So that all sounds very positive.
Very positive.
Now we're going to talk about some negative factors. What can go wrong with the total knee? Well, 1% of the time it can get loose at the bone where we cement it in place. We want you to maintain good bone health. We want you as a female to have a DEXA scan. And we want to make sure that you're taking calcium and other agents so that you protect that bone health, because that's what this rests on, is your good bone. Secondly, 1%...
And beforehand start that too? Or
I'm sorry?
Beforehand start the calcium too?
Yes.
Okay.
Yes. And we like the DEXA scan before your surgery. Now, on your x-ray, your bones look good. So we're just getting a baseline so we know what to do for the future.
Okay.
Now, 1% of the time, the alignment can be off. And it might, we have to correct that bow leg. And 1% of the time it can settle, or the alignment may be a little bit off. Now that's actually a very small percentage. In the older years, it used to be even 5 to 10% where it wouldn't be straight. And we now have some very sophisticated tools at the time of surgery that go all the way from all of our alignment rods that we use. They go to specialized x-rays. I even do computerized surgery. And on some patients, the alignment is so difficult that we hook them up to a computer. And you've heard of that computerized navigation. And so all of that is available to you as a patient. And the surgeon has to determine which one of those alignment systems is used. I can tell you in your case, you don't need the more fancy computerized equipment. By the existing equipment we have, we can do an excellent job within 1% of getting that leg lined up just where we want it. And those are very, very good.
And waiting a year or 2 or 3, would that make a difference?
Very good question. And on you, it may make a difference waiting more than a couple years because you have that thrust occurring. And what that's going to do is it's going to put more tension on the outside part of your knee. and you're complaining in part that you're having some symptoms over there,
Right.
aren't you?
Mm-hmm.
And what's happening is that outside of your joint is just kind of snapping open, so it's taking more tension. So when you, as you go through your medical program, you're going to be looking for pain all over your knee joint.
Mm-hmm.
But
Okay.
in terms of the alignment, it will not make a difference. You're still okay.
Okay.
Now, some patients' knees, instead of angling in a bow knee, they angle out the other way. And those are the worst kind.
Okay.
And those are the ones that we do want to get in early because they'll collapse into a very bad alignment.
Okay.
But in yours, you have the varus alignment, the typical bow leg. So, and we'll be following you for that, and we'll be repeating the x-rays. And if we see any collapse occurring, of course, we're going to say, okay, it's time to get in because your bone is not holding up.
Mm-hmm.
Very
Okay.
good question.
Mm-hmm.
Now, the other thing that can happen is infection. And that statistically is 1%. And I will tell you that we do surgery at hospitals, and total joint surgeons do surgery at hospitals where we really control that. And as a patient, you should know that we go through some very specialized things for infection. And that includes massive doses of antibiotics to you right before surgery. It includes skin cleansing agents that we're going to give you before surgery, that you're going to wash your skin. It includes culturing you for MRSA. There's many different steps that you'll go through when you get ready for surgery for that infection.
Mm-hmm.
And one advantage that we have is that we put big doses of antibiotics in the cement, and that gives a very high concentration of cement right around the prosthesis for a period of 3 weeks.
Mm-hmm.
And it really sterilizes, if you will, that knee. After you get your knee, it's very important that if you have any dental work or a colonoscope or any other surgery, just like if you had a heart valve or any metal in your body,
Mm-hmm.
you have to be on antibiotics.
Mm-hmm.
And so you have to protect that joint, because if a little bug runs around your body, it can get underneath this metal,
Mm-hmm.
and it's hard for your white blood cells to get there. And so that can cause an infection.
Okay.
Now, just to make you feel a little bit better, there are over 300,000 replacements done a year. And the incidence of infection after it is very, very low.
Mm-hmm.
Very, very low, like 1 in 100,000.
Mm-hmm.
So it's something that is very rare, and the body can usually handle that very nicely.
Mm-hmm.
And in my practice, and I've been doing total knee replacements for 25 years, I've only seen 2 instances where a person got an infection, and one of those actually followed a colonoscope.
Mm-hmm.
And so there's usually some other instrumentation in the body that stirs that up. So just to summarize them, we have an excellent prosthesis. It's been well designed. It's been put into hundreds of thousands of patients. There are a lot of steps that you'll go through to make sure that those little 1% of loosening and infection and that we really keep that to a very, very low odds.
Mm-hmm.
And 90% of patients are going to get a very good knee. Now, it's not going to be a normal knee,
Mm-hmm.
and you will have to protect it a little bit afterwards. And one of the things I need to warn you about is about 5% of people get scar tissue, and they won't get as good a knee with the scar tissue. They'll have little restriction of motion, and that after surgery, that first 6 weeks is very important, that you're in therapy, and you want to make sure you can go to therapy, that you have someone driving you, and you want to be in therapy for 2 days a week and then be on a home program.
Mm-hmm.
And I absolutely insist my patients are not sent to a nursing home. You need a skilled knee therapist to lead you through and get your motion back, because some people will have more scar tissue.
Mm-hmm.
And if you're a scar former, we're going to have to work double time. So about 5% of the time, patients will say, well, I'm better, but I have some pain around my knee,
Mm-hmm.
or my pain around my kneecap, or after I've been up for 2 or 3 hours, I'll have some pain. And so we can't promise you that you're going to be in that 90% category,
Mm-hmm.
but it's up to the surgeon, up to the patient, up to how you heal. And so we really want to maximize all that for you.
Now, will they know how you heal as you're healing?
Yes,
Like
you will.
You're a
Yes.
scar or you're
Mhm.
not?
Yes, yes, absolutely. And your therapist and your doctor will be checking you after very frequently in that first 6 weeks.
Mm-hmm.
Yeah, all the problems really occur in the first 6 weeks. And so that's why we really want to maximize that.
Mm-hmm. Okay.
What do you think about all that? There's a lot of information?
A lot of information.
Yeah. But overall, don't you feel a little more, I'm hoping you feel a little bit more comfortable,
Mm-hmm.
because when we say you're going to have a knee replacement, the initial human
Big deal.
reaction is
Yeah.
it's a big deal. And so really what we're saying, yes, it is a big deal, but we have many, many steps to
Mm-hmm.
make that big deal less of a big deal.
Mm-hmm.
This week alone, I've done 5 total knees. The first group that we did at the beginning of the week were all out of the hospital.
Mm-hmm.
The second group are coming out tomorrow, and they're up out of bed usually the very first day afterwards.
Mm-hmm.
So,
And how many days in the hospital?
you know, usually it's only 3 days.
Mm-hmm.
And I might mention you have a number of different pain modalities that we use to control your pain.
Mm-hmm.
And we now have what's called preemptive pain management. We don't wait for you to have pain. We get your pain management on board before.
Mm-hmm.
We do use blocks around your knee joint to block the nerves, like a dentist does,
Mm-hmm.
so that we have Novocaine there and we're helping you. We have different steps of medical medicines to help you with the pain control. And I'm going to give a little plug for the hospital that I love, which
Mm-hmm.
is Jewish Hospital,
Okay.
but it is a superb hospital.
Mm-hmm.
And it's one of the largest total joint hospitals in this area. In fact, the largest.
Mm-hmm.
And all that means is that you have this very highly skilled nursing help to really help you through all of the different, they're very knowledgeable, they take through patients this all the time, and you want that professionalism as you go through this.
Mm-hmm.
But about the 3rd day, we want you, you'll be walking,
Mm-hmm.
and then we want you in our center doing that intensive therapy.
Mm-hmm.
Good.
Okay.
All very good questions. Okay?
Mm-hmm. Yeah.
Anything else you want to ask at this time?
So that's total, right?
That's the total.
You got
um,
partials too.
Well, I did bring in the partial, and just to close with that, this is the partial, and it's marvelous because we only do part of the joint.
Mm-hmm.
And it's like a transmission. We have 1st, 2nd, and 3rd gear, and in some patients, they only have involvement of that gear. And rather than replace the whole transmission, we go in through a very limited incision and we just do a partial.
Mm-hmm.
The problem that we have is that in most patients, by the time one gear is out, another gear is out. And so this is an example actually of the kneecap. And so in this particular knee, can we just replace one gear, and then if the other gear goes, can we just replace this gear? Now, the concept of knee surgery is that you have one operation that lasts and you don't want to be coming back.
Mm-hmm.
And with a partial, there is at least a 10% chance that we have to come back within 10 years because another part of the joint has worn out.
Mm-hmm.
And we don't like that, and patients don't like that. So in your case, you already have some damage to your kneecap.
Mm-hmm.
So you would not be really a candidate for a partial.
Okay.
Now, I see many patients that are actually in their 30s or their 40s,
Mm-hmm.
and if we had seen you perhaps earlier after your meniscectomy, you may have been a partial then, and we would say, let's just do the partial. That may buy you 20 years, and then when you're in your later 50s or 60s, then we know we're going to have to come back and do the full replacement.
Mm-hmm.
This is designed to allow us to come back and do it, but it still represents more surgery.
Mm-hmm.
Does that make sense?
So do you know that now in my case? Or?
Yes, I do.
Okay.
Yes, your radiographs show that,
Mm-hmm.
and that's also a good question because sometimes we can get an MRI,
Mm-hmm.
or we can even at the time of surgery determine that this patient is not a partial and she needs a complete.
Mm-hmm.
One other little thing that I wanted to mention, this is the kneecap, and it's a little button that fits right underneath the kneecap. And again, that's a cap also, and that sits right in the center of your kneecap.
Mm-hmm.
So we really are replacing all the surfaces, and that's what makes total knee joint surgery so reproducible, is that when we go in, we're saving the ligaments, we're saving the bone, but any areas of arthritis now are replaced with these nice glistening metal and plastic.
Mm-hmm.
And so we're removing any areas that can cause pain. We can still get pain around the knee from the lining or from scar tissue, but we really are like removing the cavity. We're really removing the main arthritis.
So the kneecap stays?
The
and
kneecap
this goes
stays,
behind.
and that's a little
Okay.
cap that goes right on it.